Welcome back to another episode of the Oncology Brothers podcast. I am Rahul Gosain, and I'm here with my brother and co host, Rohit Gosain. We're excited to bring you the latest and most impactful updates from ASCO 2024. Today, we're honored to have a friend, Dr. Toni Choueiri, a GU Medical Oncologist from Dana-Farber Cancer Institute, join us to discuss some key GU abstracts from this conference. Toni, thank you so much for joining us.
Oh, thank you so much, as usual, for having me, brothers. And just came back from ASCO a week ago, and probably now we're back to baseline. As you know, we suffer after the post-ASCO blues on one hand, but catching up. So a lot of things happen. Very few are practice changing, but mostly all are practice informing. I want to start with one of the top abstract oral presentation by Dr. Gupta from Cleveland Clinic, adding to the EV302 study of enfortumab vedotin plus pembrolizumab. That study already published, presented last ESMO meeting, showing PFS and OS benefit in first-line metastatic bladder cancer, change a standard that has been 3 decades. And in this study, Dr. Gupta looked at the patient-reported outcome. Not surprisingly, in a disease that, in a regimen that has activity, significant activity, and acceptable toxicity, enfortumab vedotin plus pembro led to a meaningful improvement in quality of life. The global health status, quality of life was improved. The data collection was excellent. And I think overall, when you look at the multiple changes in several quality of life parameter, wanted to focus on the EORTC, QLQ, C30, they're all favoring the combination of pembro EV. So this complements very well the PFS and the OS data. And the question, as you know, for both of you, two regimen that at the same time improve survival, pembro EV or gemcis nivo over gemcis from Checkmate 901, which one to use? And most of the folks are using pembro EV, but Dr. Galsky presented some subgroup analysis, very interesting, that look at patients, those 20%, I would say, not more, that have actually lymph node positive patient. And those patients do very well because they have higher rate of complete response. And the question is, could these patients preferably get gemcis nivo rather than pembro EV? And the simple answer is that I do not know. In my practice, no, I would use pembro EV because the responses were in all sites. But we have to understand, in many places outside the world, or I don't know if some people can't get this regimen reimbursed, gemcis is available, and you're adding on it a drug like nivolumab that is very available, and folks are familiar with very much. But certainly striking difference and activity in lymph node only patients.
Well, thank you so much, Tony, first of all, joining us right after ASCO. I'm glad that you're all caught up with 5,000 of your emails. And again, Tony, it is important to stress that your work in supporting IMG Medical Oncologist is also commendable, along with all the things that you do. Now, sticking with our theme of GU from ASCO 2024, as you rightly said, enfortumab pembro combination ended up doubling of overall survival, which resulted in standing ovation at ESMO 2023, and rightly so. But here, with Dr. Shilpa Gupta presenting the data from patient-reported outcomes, is again incredible. In metastatic space, our treatment should at least increase overall survival or at least improve patient quality. and ideally both. And this combination particularly does that. And now you're pointing out the chemo Nivo arm, which has again resulted in such significance from survival standpoint. The choices are EV Pembro versus chemo Nivo. But again, how convincing EV Pembro is, one would rely on that. But again, in limited resources setting where one can't get reimbursed, rightly so, we will be sticking with chemo Nivo.
Or
Yeah,
chemo alone as well, right? Because again, some parts of the world might not
Right.
even have that access to immunotherapy. So I think our frontline therapies are now three rather than just two: EV Pembro, chemo with Nemo, and
Right.
then of course chemotherapy alone.
I
Yep.
think that's a good message overall, that the biology of lymph node only disease is different, and it's a distinct clinical entity. And if you don't have access to Pembro, if you're doing GemCis, and ideally adding nivolumab on it, hopefully nivolumab is available, will make the trick. The CR rate, overall response rate, the median PFS. The median PFS in lymph node only goes from GC, GemCis, almost 9 months to 30 months. So
Right.
if you don't have access to Pembro EV, this is a very
Right.
reasonable option.
Absolutely. And again, just to reiterate, prior to all this, the other standard of care was continuing with avelumab in patients that had response or stable disease based off Javelin study. All right, talking about how this space is moving quickly, another hot topic here ends up being ctDNA. Tony, based off Keynote 361 in bladder cancer, which again essentially was a negative study, but here at ASCO 2024, we've seen some updates based on ctDNA displaying a prognostic role or value. In today's practice, outside clinical trials, are you regularly using ctDNA in your clinic?
I am not. In prostate cancer, you have PSA, which still in many clinical scenario and most is useful. In renal cell ctDNA, at least the bespoke assay has not been sensitive. In bladder cancer, perhaps, especially in the adjuvant setting for MRD. But I think adds another piece. This paper by Dr. Powell's add another
Mhm.
piece of information that ctDNA among all GU malignancies may be the most ready. And again, when we say ctDNA, could be, many things, but this is a ctDNA that looked at, this is the Guardant Omni assay that look at maximal detected variant allele frequency. This is the one that actually um, looked at, and it does have match normal and paired tissue. So important to know what are we looking for. Um, and again, this average mutation detected and then cleared. And in this work, not surprisingly, baseline ctDNA level were associated with clinical outcome
Yes.
in chemo, but not chemotherapy, and with Pembro, sorry, but not chemotherapy. And the changes were more associated with long-term outcome. So I think this is the dynamic of ctDNA can be influenced by what mechanism of treatment, which is important, practice informing, though I'm not using it in my practice, but certainly for the future. I think the story of ctDNA in GU malignancies is way back compared to colorectal cancer and other malignancies. But, you know, um, platforms are improving and integrating methylation, integrating the epigenome. So things are going to get better with time.
Absolutely.
Thanks for covering that, Tony. And I'm going to piggyback on a very similar topic. In RCC, use of KIM1 as a prognostic and a predictive biomarker. We saw more data on this biomarker. Tony, your thoughts here?
Yeah, no, so interesting, especially with ctDNA not being shed much. Kim1, people have been working on it over 25 years. Dr. Joe Bonventre used it as a kidney injury molecule in patient with actually kidney injury. Dr. Bonventre from Harvard, my colleague from the Brigham, nephrologist. But then the past 5, 6 years, this was taken to look at renal cell cancer. And there's a lot of data led by Dr. Vincent Chu that showed this biomarker predict early on recurrence and could serve even as screening. And here, another study that failed actually in renal cell. That was Emotion 010 adjuvant atezolizumab negative study in renal cell. But actually, if you look at patient with SCIM1 high, the study favored atezolizumab. So now we're linking this biomarker to therapies and resurrecting treatments that didn't work and make them work again. So certainly the question here, what is the importance of this biomarker? Perhaps less so in metastatic disease, but more in the adjuvant setting with pembrolizumab, especially that's the only approved adjuvant study in adjuvant drug in kidney cancer. So hopefully we're trying to work on this now, since this is an approved treatment. And in adjuvant, in all tumors, not just renal cell, we end up over treating.
Yeah, no, I think that we hope to get more clear data on how to use ctDNA so that we can select the right patients rather than under or over treating, right? Okay,
Correct.
sticking with the theme of RCC, at GU ASCO back in January, we saw some updated data for Checkmate 214. Historically, Ipi-Nivo has stronger data for intermediate or high-risk metastatic RCC. But with this update in January 2024, we saw improved overall survival even in favorable category. But coming back to ASCO 2024, based on real world data and international database consortium, we saw that IO with TKI did the best. Tony, your thoughts here when we're looking at favorable versus very favorable, and what are you making out of this data today?
Yeah, no, I mean, the IMDC, which we started in mid 2000, was the first publication, was in 2009, was my co-founder, Dr. Danny Hang, a very good friend of mine. It's almost like the gift that keep on giving and informing practice. So what we've done here, of course, we put it in the setting and in of current therapies, which is VEGF IO or VEGF plus IO. You're right, Checkmate 214 initially and still approved currently in intermediate and poor risk disease based on the PFS and response rate favoring single agent sunitinib in favorable risk disease, those 20-25%. But what's seen was more update, including the update Dr. Tanir gave in ASCO GU 2024. We've seen now two things. First of all, yes, the PFS and the response rate, which is two important endpoints, continue to favor sunitinib. That's correct. But the CR rate are double with Nivo Ipi in the favorable risk, and these are more durable. Not just double, each CR, I mean, is more durable than the CR from sunitinib. And important and more important is that after 8 years of follow-up, the hazard ratio for OS now is 0.82 favoring Nivo-Ipi. So if someone in the favor risk want to use Nivo-Ipi, it's not wrong. They would say, yes, the PFS, perhaps for a general population of favor risk, the PFS and the response rate are lower, but the CR rate and the overall survival are better. So it's justified to use it if people really want to use it for whatever reason, such as small disease burden, lymph node only, no need, contraindication to VEGF TKI, etc. What we show here with Dr. Martin Zarba, actually, who is one of the fellows in with Dr. Hang. Um, is that there is a group we reported on a few years ago inside favor risk, which is the very favor risk. So 30% of favor risk are actually very favorable, meaning what? They have no bone, no liver, no brain metastases, great performance status. And from diagnosis to therapy, it's 3 years or more, not more than 1 year. And those patients seem to be more and more addicted to VEGF inhibitor to a degree. What we showed that IO VEGF has the best response rate, the best data, but 2-year OS and objective response rate is lower with Nivo IPI. I think that's fine overall because that takes over all the population and not the single patient. But
Absolutely.
it's important to include a VEGF inhibitor in this patient subset. I still think even in the favor risk, it's fine to treat with Nivo IPI if you believe the disease is not going to get out of control, but keep your expectation low. If you had this CR, that's great, and render the patient, cancer free. That is great, but the chances is lower and lower. You go from poor to intermediate to favorable to very favorable. The VEGF inhibitor become more important, and these tumors are angiogenic at heart.
Raul, you mentioned the topic of overtreating patients and undertreating. I feel like would be one of the settings where ctDNA could be utilized, and we don't know if there is a marker which will tell us if TKI single agent is the right option, where we can rather undertreat and still get quite an outcome with that. Now, switching gears to prostate cancer. Pluvicto has been an approved option in metastatic castration-resistant settings after one has utilized docetaxel. But in PSMA4, we have seen utilization of Pluvicto after ARPI, before docetaxel. This study was talking about health-related quality outcomes, also pain aspect of patients seeing benefit with Pluvicto in earlier line. Tony, your thoughts here?
Yeah, no, I think honestly, guys, this was not a surprise, but the quality of life, yes, favored. Um, you know, um, Here overall, Pluvicto, the fact P total score, we have to be careful when we talk about what kind of quality of life. But let's say the first graph, the time to worsening in pain intensity, more time on Pluvicto than ARPI change, which, it's probably not a lot of activity, and the fact P score. But what was snuck in at the end here in this presentation was the hazard ratio for OS. In PSMA4, when the first presented, the hazard ratio for OS was over 1. And here in a
Yes.
health-related quality of life, and I wasn't following the field very well here, snuck in that now, hey, the hazard ratio for OS, which is great. This is very comforting. The hazard ratio for OS is less than 1. We always like to see the less than
Right,
1. So this is good. I don't know, will I be using it before
right.
chemo? This is pre-chemo, taxane naive. I mean, in my experience, been using chemo. I'm an old geezer here. Um, it's not horrible. Chemotherapy is not really horrible with how we premedicate patient, etc. We get away with a lot, but I think in my practice, I would use lutetium PSMA still post chemotherapy, but this is um, uh, results that are kind of relieving
Right.
for us, that at least the hazard ratio for us is less than 1. I'm not surprised with the quality of life. It is better. It's not hugely better. The difference in the total score was 3 months, and the time to worsening was 2 months, etc. But at least it's the step in the right direction to have an OS that is not inferior.
Right. Again, I would agree that this is something that we still have to wait and how it pans out for taxane naive population. But as of now, FDA has approved it for taxane basically as a second line after taxane has been utilized.
Correct.
Tony, thank you so much for covering all these exciting studies from ASCO 2044. Yes, we did not see ground shattering data like lung, GI, or breast cancer, but these studies are very, very important in practice informing, at least reiterating the current standard of care. For our listeners, let us go over a quick recap.
With Dr. Toni Choueiri from Dana-Farber Cancer Institute, we have covered key studies, including EV302 study and its quality of life outcomes, the use of ctDNA in bladder cancer from Keynote 361, real-world data on metastatic RCC from the International Consortium for Favorable and Very Favorable Disease, and then the PSMA-4 study. These studies highlight the importance of patient-reported outcomes, the potential of ctDNA as a biomarker, and the value of risk stratification in metastatic RCC.
For advanced urothelial carcinoma, the combination of EV and pembrolizumab is now new standard of care. However, in lymph node-only disease, chemo with nivolumab might be a viable option. When it comes to ctDNA, it continues to show promise as a tool for real-time monitoring, but it is yet to be part of our standard of care approach. The International RCC Database Consortium emphasizes tailored therapies for favorable risk profiles in metastatic RCC. We also discussed the evolving paradigm in PSMA targeted therapies and its sequencing in advanced prostate cancer, particularly from health related quality of life and pain outcomes. Thank you for tuning in. Be sure to check out our other discussions from ASCO 2024, GI, GU, and breast cancer. We are the Oncology Brothers.